My name is DePrince. I'm Director of Jefferson's Neuroscience Network. My experience began in 2012 when I joined Jefferson's Neuroscience Network. It was mainly to provide acute stroke support to 35 hospitals in the region, and since then it has evolved into outpatient neurosurgical telemedicine visits, virtual rounds, and neurocritical care coverage using telemedicine. The neuroscience department decided to use telehealth as a way to increase patient access to neurology care in the region. We have 35 hospitals that access our telestroke network. Our physicians are able to beam into a robot within 15 minutes of a telestroke request and provide specialty care using telemedicine. The decision to use telehealth in the neuroscience department was made because we recognized that neurologists in the community are at a great shortage. So we needed to find a way to improve access, and telehealth was the vehicle to do that. So through telemedicine, we've been able to provide more than 6,000 telestroke consults to hospitals in the region. And prior to having telemedicine, it was just patients that came down to Thomas Jefferson, so only within our walls or our campus. So I think the greatest influence has been in access. There was a great case that telemedicine was recently used in a hospital that's about 100 miles away. It was an inpatient stroke that was admitted with a different diagnosis. She woke up in the morning to prepare for her day and collapsed in the bathroom. We had provided a mock stroke alert there recently, and the nurse immediately recognized that this was a stroke-like symptom and called for the rapid response team. When the team arrived, they requested a telestroke consult, and one of our specialists beamed into the robot and was able to evaluate the patient rapidly and determined that she did qualify for an intervention for stroke that would not be available at the community hospital. We arranged a quick transfer to Jefferson, and that patient did have a mechanical thrombectomy for treatment of stroke. Her NIH stroke scale, which is a stroke severity scale, was 19 upon her arrival, and she was discharged to home 4 days later with an NIH stroke scale of 2, which is a very mild stroke and leaves the patient independent and a good candidate for rehab. Education has been the cornerstone of the success of our neuroscience program. We not only use telemedicine as a way to evaluate patients and provide specialty consults, we also use telemedicine as a way to provide education to clinicians in the hospitals that we serve. Treatment rates for acute stroke are 3.5 to 5% nationally. In the neuroscience network, our treatment rates are 19%. So that's something we're very proud of. I think it's all about communication. I think understanding workflow in each hospital, sharing clinical protocols so that hospitals don't have to reinvent what they do, and having the right type of specialty support are some of the biggest factors. I think telehealth is the future of medicine. We're using it in acute settings, we're using it in homes, we're using it in an outpatient setting. So I think it's a very exciting time to be working in telehealth. The benefits of a training program for telehealth coordinators are great considering the healthcare climate that we are working in. We need educated personnel to help with the various technologies and understand the different uses for telehealth.